So, hi everyone. This is the burst session for the cultural consideration in early psychosis with adolescent and college students. And this will be from 4:30 to 5. If you found yourself in the wrong session, just go over to the left corner or the left toolbar and click sessions and then go to the correct one. And the chat is on your right. And if you have any questions, you can put them in the Q&A column, and me or Kelly, well, Kelly's having technical issues right now, but we are both the moderators, so we will look for that. And your questions about our presenter. Dr. Joseph DeLuca, PhD, is from the Icahn School of Medicine at Mount Sinai. Joseph is an NIMH postdoctoral fellow at the Icahn School of Medicine at Mount Sinai in New York City, specializing in psychosis risk and the early stages of psychosis. He earned his PhD in the clinical at the City University of New York Graduate Center and completed his pre-doctoral internship at the University of Maryland School of Medicine. Dr. DeLuca's research and clinical interests include screening and treatment for psychosis spectrums, particularly with youth and families, as well as stigma, the roles of cultural and context in psychosis, and the intersection and criminal justice system. So, it's all yours now.
Thanks so much, Jenny, and Kelly as well. I know you're working on your mic. Thanks for monitoring the chat there. So yeah, Joe DeLuca. I'm from New York City and specialize, as Jenny said, in early psychosis. So primarily working with adolescents and young adults who are either showing warning signs or sub-threshold signs of psychosis, maybe seeing things or hearing things for the first time. And also, we interact with some young adults in our clinic who are just experiencing a first episode of psychosis. So have been diagnosed with schizophrenia, for example, for the first time. So I see we have a few people here. I don't know how many people were at my earlier presentation where I had some slides and talked about what these phases look like and how to do assessment in a culturally sensitive way. And I gave some practical resources. So if you were there, I'm happy to answer any follow-up questions or lingering questions you have. And I figure I'd start this out just in general, even if you weren't there this morning. If anyone had any opening questions about, what is early psychosis, how do we assess for it, anything else you're thinking, please feel free to put those in chat. What you're hoping to learn about this topic. So I really appreciate you being here. Happy to make this as personalized as possible. Ginny, maybe while we're waiting for some potential questions to come in, would you mind actually pulling up the slides? Maybe I could start on slide 8. I think that could be helpful to show people. Yeah, so that's a good question. So I see your question there, Mary, both about the session. I'm not sure about that if it's recorded, but you will be able to get a handout of my slides. Oh, thanks, Jenny. I'm seeing your response now. And then great question, Mary. So the clinic I work in, is, if you can see the slides here, is primarily a psychosis risk clinic. It's the first category of early stage psychosis. And we typically work with youth as young as 12. What we know from the research is that prior to age 12, you can get a lot of false positives just because kids, have big imaginations just because they're kids, and it can be hard to disentangle, what's imagination and developmentally appropriate versus what is psychosis. That said, there is a rare disorder called childhood schizophrenia, which I don't specialize in, we don't work in these clinics in, But there are some rare cases of kids, in later childhood, like super early adolescence, who may have severe, disorganization, hallucinations, delusions. Yeah. But in some, our clinic mostly works with age 12 to 25 or age 12 to 30. So great question, Mayor. If any others have any questions, feel free to add, but I can go over some of the phases here. So like I said, I primarily work in this psychosis risk phase. It has many different names. It could be clinical high risk for psychosis, ultra high risk. Sometimes people have called it prodromal or the prodrome. And these are warning signs, like subthreshold signs. So I can give you a few examples in a minute. But these are psychosis-like experiences that look like psychosis, but they wouldn't meet criteria for a DSM-5 psychotic disorder like schizophrenia. So some of the experiences that we see in our clinic, yeah, that's a great question, Mary. So that's actually a good one. I could use that for an example. So it's typically outside of their head, right? So we ask them if it feels like it's coming from somewhere else. If it's something that we, hear like, oh, it's inside of their head, we may want to pull that apart a little more, right? It could be like their conscience, or it could be like negative self-talk. I don't want to diagnose psychosis in that way. I'm working with a kid now, right now, for example, who, she lives at home with mom and dad and a few siblings. And sometimes she hears her name called at home, or like a baby crying, but there's no baby at home. And 95% of the time when she asks her mom like if she was calling her, she wasn't. She also sometimes hears like knocking coming from somewhere, but there's no knocking. This person also has some like sub-threshold visual hallucinations that again don't reach criteria of schizophrenia, but appear to be in this risk state. They sometimes see shadows out of the corner of their eyes, and then when they look, it's not there anymore. But again, the thing about psychosis risk is that these people can induce doubt. So this female I work with, a young teenager, she's like, oh, I know this isn't real. It's just like these strange experiences. I still get my schoolwork done for the most part. It's like a little distressing. Have some treatment for it. So those are some examples. Kelly, that's a wonderful question. And yes, absolutely. So we know that there is a connection for sure for some people between trauma and early onset psychosis. We know that there's a pretty significant relationship specifically between childhood sexual abuse or just sexual abuse in general, and psychotic experiences, but really any abuse, any neglect, any trauma you may have witnessed or experienced or victimization, we know that increases your odds of having psychotic experiences. That said, that brings up interesting questions always around sort of, is this psychotic disorder or is this PTSD with psychotic features? So, in those cases, in order to disentangle that, we'll want to do a really good assessment and timeline of symptoms, right? So for example, did these symptoms start, after that abuse? Were you having any symptoms before? Do these psychotic symptoms or weird symptoms, seeing things out of the corner of your eye, do they happen like when you're having flashbacks, right? And if we get a lot of affirmative sort of that it looks like it's tied to the trauma, it may be more of a PTSD presentation. But yeah, short answer is yes. We even know racism, discrimination, heightened stress sensitivity in general can definitely lead to these experiences. Yeah. And just in case there may be some more questions coming in, I'll just add a little more to that. So as I'm sure a lot of you are familiar with, what we think about when it comes to how a psychotic disorder is caused is a diathesis stress model, or a stress vulnerability model, it's sometimes called. And that basically means that some people have a predisposition toward developing a psychotic disorder. And that could just be due to family history, for example, or certain genetics. If you have a parent with schizophrenia or a psychotic disorder, you're at a 10 times greater risk of developing psychosis. But not everyone does, right? So just having a risk or a vulnerability doesn't mean you'll develop a psychotic disorder. But adding in the stress component, we know people who have a vulnerability and then have a lot of stress or trauma in that environment, that could create a perfect storm of causing these psychotic experiences. So absolutely. Mary, that's a wonderful question. Do you hear general themes in young people's reporting of hallucinations? Yeah, so let me think about auditory. So we do, or at least anecdotally from my experience, I have heard a lot of, what this girl I'm working with right now reports, hearing like a family member calling them or a friend calling them, sometimes ear ringing, we'll want a medical workup as well to rule things out, but that comes up. Um, Maybe hearing like friends call or, say things behind your back, like whispering when they're really not. And, those kind of things make sense, especially the friend things. There's a lot of self-consciousness during adolescence. And, that could exacerbate to an extreme level for people and they could have psychotic experiences. Um, so those are some of the main auditory ones that are coming to mind. Sometimes we've had youth who hear multiple voices, maybe like arguing or telling them that they're bad people, that kind of thing. Uh, in terms of visual hallucinations, like shadows out of the corner of your eye, that's kind of like a classic clinical high risk for psychosis symptom that comes up. We hear that a lot. We also hear sort of like flashes out of the corner of your eye, or maybe seeing like a bug or like a rat or something go across the room and you look and nothing's there. Um, Sometimes objects can look differently, right? So someone may think like at the corner of their eye, or like they look up, they think the door is open, but it's actually not. Um, it's also important to recognize, and Mary and others, you may know this, that hallucinations, right, can be auditory, can be visual, but they can also be tactile. So we work with kids who sometimes feel like, odd sensations on their arms or somewhere else in their body, like vibrations or fuzziness. Bugs crawling on them is something that has come up quite a bit that I've heard, or like someone touching them and like their back or something when no one's around. Um, and then there is also olfactory or like smelling hallucinations that can come up. So I have a handful of kids who've reported things like, smelling garbage or sewage. And in those cases, we want to ask the question like, oh, does anyone else in your household or anyone else around you smell that? And in those cases, family members said like, no, we don't smell that, or smell like rotten eggs or something. So, great question, Mary. Yeah, it can be sort of a range of things, but there are some of these sort of peer-driven themes or, excuse me, paranoia that can come up for sure. And just if people are thinking about other questions, I could jump quickly to number 2 here, first episode psychosis. So that is a period that is, where someone is meeting criteria for a psychotic disorder. So, they are fully convinced, that they're seeing things that others don't and hearing things that others don't. It's happening much more frequently than in the risk state. It is severely impacting their functioning. They may seem disorganized in some ways, maybe disheveled in terms of clothing and taking care of themselves. So that is a more severe situation. And the treatments for each phase are a little different. So for psychosis risk, it's more of a preventative sort of transdiagnostic treatment that we're doing. This is a group of people, we cast a wide net. They have these, subthreshold experiences. Only about 20 to 30% go on to develop a psychotic disorder over the next few years. A study actually came out today, I was reading it this morning, that at a 10-year follow-up, 35% of that psychosis risk group disorder. So one, that's a pretty significant minority of this group. But two, I mean, that's also leaving about 60 to 70+% who don't develop psychosis. And the people who don't develop psychosis, a mix of them, their psychosis risk symptoms stop, some remain the same, some get a little worse. And a lot of these kids have comorbid conditions. So there's a high rate of anxiety and depression in this group. So we're typically treating that. We treat a lot of like social anxiety, for example, major depressive disorder comes up, OCD. So it's pretty interesting in the psychosis risk program because I'd say, in my experience, the majority of the time, we're actually not treating the psychosis risk symptoms because when we work with the kids and families, they're like, yeah, it's strange. I may see something out of the corner of my eye. It's a little distressing, but like, the social anxiety is killing me. Like, I need to work on that. So, we do a protocol to work on social anxiety. And, a fair amount of time, once we treat the depression, the anxiety, those psychosis risk symptoms tend to go down as well, as stress gets reduced. So yeah, we sort of do like this modular transdiagnostic model where, we work very collaboratively with teams and families. For first episode psychosis, the treatment is typically more intensive. You may have heard of programs like coordinated specialty care. These are pretty intensive outpatient programs with multidisciplinary teams who provide, individual, group, family therapy, medication management, vocational support, substance abuse support. These programs typically have 24/7 crisis lines. So it is a higher level of care because it is a higher level of sort of symptoms being presented. Yes, those would be the main. And if you weren't here this morning, you will get access to my handout, and you'll see that there is a program in West Virginia that focuses on first episode psychosis. Mary, thanks for the comments. Wonderful. And questions. Yeah. So Mary, I'm really glad you bring that up because, strange experiences happen due to medical issues too. So, whenever I'm doing an assessment, I'm not a medical doctor. I have my PhD in clinical psychology. So, I can assess and, psychiatric perspective, but we always want a medical provider involved to rule out other things. You are right that olfactory hallucinations can be related to neurological problems. So can visual hallucinations. Even things as simple as, like an eye exam. Whenever kids have odd visual experiences, we want to make sure, okay, have you had an eye exam recently? Have you checked that out? Could it be a floater, right? We want to do a really thorough evaluation. Similarly, we know medical conditions can lead to psychotic experiences. Like I believe for some people, mononucleosis and complications can sometimes lead to strange experiences. So we really need to be doing a very good medical workup for folks. So great point, Mary. Happy to answer any other questions. While we're waiting, if there are any others, Ginny, if you wouldn't mind, maybe you can go to slide 30. I can show people the Prodromal questionnaire and what that looks like and how to access it. Thank you. Perfect. Thanks so much, Ginny. So if you go to, perfect. Yeah, if you go to psychosisscreening.org at the bottom, resource developed by, I think, folks in Boston and the New England area. And they offer you free the Prodromal questionnaire, the PQ-16. And these are 6 example items. And you'll see that this is something, if you're a clinician or if you know a clinician, you could start using. And it can give you a good sense, if someone is having some of these either psychosis risk or first episode experiences. You'll have to look on the website for the cutoff. I believe offhand, the positive screen cutoff is 6 items endorsed. So if you mark off 6 of these as true, that would be a positive screen. That does not mean that you're at risk for psychosis, but it means that there should be a more in-depth evaluation by someone who's expert in this area to determine that. And you'll see that we're also really interested in distress, right? So it's one thing to have some of these strange experiences and for them to come up, but are they distressing? Are they impacting your functioning, right? We really need to know that too. That could guide treatment planning. It also guide diagnosis, conceptualization. So this is a great tool. This is something that we use here in my clinic as a first line. It's actually given to pretty much everyone who comes into 4 of our child and adolescent and adult outpatient clinics at Mount Sinai. And then they're referred to us if there's a positive screen. That was a study that we had done. So we were getting a lot of referrals. And you may be surprised that about 20 to 25% of clinical samples are at risk for psychosis. So it's a big number. A recent study I saw was 25% on an adolescent inpatient unit. So you are connected to or work near an inpatient setting, I mean, you really need to be doing these, targeting these things. Yeah, what I have found in this work is that, kids sometimes feel like these experiences are so strange and, no one would understand, like, who else experiences this? So unfortunately, a lot of teens like never verbalize this until they get to like working with me and like our specialized clinic. And a lot of clinicians can miss this and not ask about it. And it's not their fault. There's just not a lot of training out there, unfortunately, on probing and looking out for these experiences. And there's a lot of stigma toward these experiences, so it can make it really difficult for youth to speak up about this. So just a little background on these two sort of phases within the early psychosis umbrella and a concrete screening tool you can use. Maybe the last thing I'll have you go to, Jenny, if you don't mind, is the cultural formulation slide on page 33. Slide 33, rather. Thanks. So please feel free to ask any other questions if you have any, and I'll just go over this slide quickly while I'm looking out for the chat. And this was part of my presentation this morning. One, just doing this work is very important because kids who are having these psychotic experiences are under-detected and under-treated. But two, I mean, for this work to be most effective, it needs to be culturally sensitive. So ways we can do that, we're using the cultural formulation interview. So, okay, you've had some of these, hallucinations, or that's what it looks like. You're seeing things or hearing things, like what brings you here today? You'll see some questions here. How would you describe the problem, right, to friends and others, right? We really want to get a sense of the language that they use. And this is a free tool available online, developed by the American Psychiatric Association, which helps us get at some of these cultural aspects of mental health in general, and it can be used specific to psychosis. Any other questions from anyone based on anything I've covered here, or any questions in general you have about psychosis? Happy to answer. No silly questions. People are also welcome to share in the chat where they're coming from and like what type of school or setting they work in. I'd be curious to see that too, if you don't mind sharing. Okay, great, Robin. Wonderful. Yes, Siri, sure. So Robin, I'm glad you wrote that, and no pressure on the teachers, because teachers, as we know, we're overloaded and doing everything above and beyond all the time. But one way that teachers and I think schools can help with this issue are to have sort of like mental health presentations, connecting with organizations like NAMI, the National Alliance on Mental Illness. They can provide you with guest speakers who can come to your class, and many of those speakers have had psychotic experiences, and we know from the research that having presentations like that can reduce stigma and destigmatize the narrative. Yeah, Mary, those are wonderful questions. Yeah. So in our program, in addition to that transdiagnostic modular care, we do some group therapy, and we do family therapy too. So I'm seeing two families tonight for therapy, and I run a group as well, and a social skills group. So yeah, a big part of the psychosis risk treatment is normalizing these concerns, right? I know I've said a few times, right, these are strange, these are unusual, but they're not as rare as we think. And everyone in this room has had strange experiences, right? I bet we've all had superstitions, or thought we heard something sometime we didn't, or thought our phone buzzed when it didn't, or it rang, right? It's a human experience for the mind to try to make sense of the environment. So yeah, groups can really help. Great point, Mary. And welcome, Leslie. Wonderful. Yeah, feel free to use these tools and reach out to me if you have any questions. And same for you, Alyssa. And that's awesome, Robin. Great. Yeah, I think that would be cool on multiple levels. So, maybe NAMI can talk a bit about careers too, and they often have volunteer opportunities. So yeah, I definitely look up, NAMI in West Virginia near your local location. Perfect. Thanks so much, Kelly. That's wonderful. And they provide presentations free of charge. They might be doing them virtual now because of the pandemic. But yeah, definitely reach out. And if you don't mind me asking, Alyssa, Leslie, have you seen things like this come up before in your work, like sort of early psychotic experiences, or it's not something you've seen? And anyone else who works in a school, Robin, if you've ever heard of that. Okay. Great. Really appreciate all the responses, the comments, the questions. Okay. Siri, thank you for letting us know. Great. Alyssa, okay, great. So you've had some experience with that. Wonderful, wonderful. Yeah, again, these, I don't get any money or compensation from these tools. They're freely available. So just trying to spread the word. If people want to use them, it could be a nice way to structure, intakes if you wanted to add it to something like that. And again, you have the program in West Virginia. Maybe that could be the last slide we just end on here. Ginny, if you don't mind, it's slide 35. It's 2 slides forward. People can see, and I'll put that in the chat as well. This was the only program that I came across in my research that does first episode psychosis work in West Virginia. They may also do psychosis risk, I'm not sure. But that may be a nice local resource for you guys if you have questions or need to refer someone as well. So feel free to check that out. And then that's an international and national map. Those are links there you can go to in case you know people in other states or regions that you'd like to refer or just get to know what is out there. I see we're coming to the end, but happy to stay another few minutes if people have any other questions or want to talk about anything. Yeah, absolutely, Kelly. Happy to be part of this, and thanks again so much for all the coordination. And likewise to you too, Jenny. Thanks for helping me out with the slides and the nice introductions today. It's much appreciated. All right, well, if no one has any other questions, I'll stay on a minute or so, but feel free to head out if you'd like and enjoy the rest of the conference. It's been a pleasure.
Yes, thank you so much. All of this, even the little burst session, even though I sat in on the big session, was super informational. Such an important topic. So thank you so much, and thank everyone for dealing with all of the technical issues that we were dealing with today. It's what happens when you have a big virtual conference on a site that no one knows how to work sometimes. And thank you, Kelly, for helping me moderate and giving me this responsibility. And thank you, Dr. DeLuca. Everyone have a great evening.
Bye, everyone.